My name is Komal. I'm an OBGYN geneticist by clinical background and a healthcare quality and safety expert. My comments are really framed as someone who has been cared for using ambient technology, someone who really thinks at scale about regulatory issues and reporting nationally. I will fully disclose that as a clinician, I have not yet had the opportunity to use technology as a provider. It just hasn't been in the places that I've worked, and so I look forward to that.
Awesome.
Hi, my name is Nancy Sabati. I'm a primary care physician. Up until recently, I was the ACMO of BILH, which is Beth Israel Lahey Health. If you don't know BILH, we are the other health system in Boston, which won't be mentioned. My role as an ACMO was to roll out Epic, which seems to be a theme in this room. So we completed that in October. But more importantly, I also had the opportunity to roll out an AI scribe across our system. And that's where I met Heidi Health. My current role is the US-based CMIO of Heidi Health. So I have jumped the fence to the other side. So I bring the clinician view and what that looks like, the implementation view, and now where we're going in the future. And if you haven't met our fabulous team or visited our table, please do.
Yeah, and so let's start with that experience. So tell us, walk us through like a day in the life of the primary care physician before you got the scribe, in this particular case, Heidi, and then what does that look like afterwards? And then we'll get the patient experience as well from a doctor. Isn't that weird? That's what you get at Health Impact, the patient experience from the doctor.
Yeah.
Go for it.
I mean, I think we've all known that primary care is in crisis. 20 patients on your schedule, you're struggling to keep up with the phone calls, the messages, prior to having an ambient scribe, I would be there late on a Friday evening. My husband would know I wouldn't be home much before 8:30 because I'd have to complete all my notes. This is totally different. So I walk in the room, I put, you can use different recording devices. You can use your phone, you can use your laptop, your desktop. I use my laptop. I get consent from the patient. I click, start recording, and I put it aside. I'm actually facing the patient. I'm having eye contact. I'm not on my computer typing. It is a totally different experience. At the end of the visit, my note is organized. It's in my words. I can print out a patient explainer so the patient understands it. It can be in their language. And my note's done at the end of the day. It is truly such a game changer and life changing.
So what about the prep side? Is that something you guys have looked at today?
Yeah.
So the post, I hear a lot about the value on the post experience, just like you said. What about the pre-experience when the patient walks in?
Yeah, and that's really key. In primary care, you're trying to put together so many different pieces of information in order just to step into the room to see the patient. It's the discharge summary, it's the echo, it's the labs. And what Heidi has done is created this context section where I can put into that all this information and ask it to summarize for me. So when I'm going into the visit, that information is already there. I know what I'm talking about. I know what happened to the patient. I'm not spending, I mean, sometimes like prepping for a full day of patients, I spend a couple of hours beforehand just to prep. I don't have to do that anymore. That's being done by the AI.
And the nature of vitals collection and the other things that are ancillary before they get into your room. So as patients, obviously, we're going through multiple stages. We walk in, we get the check-in, we're put into one room to wait around, and then we go to another room to wait around. Some of that will stay the same, but how does that pre-part of it with vitals, et cetera, change, if at all, with Scribe?
So you can place that into the context so you can summarize that data. So, we've talked about things like RPM, you can dump the RPM data into the context and say, okay, the average blood pressure was X over the last 2 weeks. That way I'm already going into there saying, hey, you know what, we need to adjust your blood pressure medicine. So all that information. And the other thing that's really nice is it is very flexible. It is, what I want as a primary care doctor is not the same as what a cardiologist or a urologist wants. So I think, we start thinking about, whether it's ambient or other AI technologies, the flexibility is really key
Mhm.
because we all think differently, we all document differently, and that's what I think, really drew me to Heidi.
And if you were to ask your colleagues, some of them are not doing it yet, some of them are doing it. What have you guys talked about?
Sure.
And this is a safe space. You can tell us anything. Where is it like mostly bullshit? But where is it like, oh my God, this is so much better than I thought it would be? Because you got to have both. I mean, no tech is going to be just perfect all around. And it's not going to be Heidi's fault, but there is some things as a physician that you do that it probably can't handle today, or that you're learning how to handle.
Yeah. So physicians want, clinicians want more.
Mhm.
So, I've been like the Epic person implementing Epic, and nobody gives you high fives and hugs when you walk around to the clinics saying, thanks for Epic. But you go, and I did a number of site visits, in December with our Heidi users, and they use words like, I love this. This is a game changer. Thank you so much. This is the best thing, our hospital system has done for us. I mean, that truly is a different experience. But then they say, well, I wanted to do this and I wanted to do that. And that's great because, when you put a technology into the people's hands who are using it, then they come up with things that you didn't think of. And, we even saw this with, so I spent some time with some urology residents, and they were using this to create sign-ups to their colleagues to prep their surgical cases. So really lots of instances, outside of the usual visit is where we have found tremendous value.
Very cool. So remember, if you guys have questions, pop your hands up. But Komal, I'd love, oh, you have a question before I jump to Komal? Go ahead.
I was curious about which service lines, if you had any observation about which service lines tend to be more optimizers or champions or users. Where has it been most beneficial, if it is by service line, or how do you?
So we have about 2,200 users right now. Half are in primary care, and that's great because we knew there was a real need for it. The rest of it is across specialties. In terms of the benefits, and I know the literature is a little bit iffy in terms of this is truly a time saver. We have an article coming out that's showing that on average, about 3 minutes per visit is saved. And if you're seeing 20 patients, that's huge. But if you look at specialties like psychiatry, neurology, where their notes tend to be long, they're actually saving about 6 minutes per visit. So we're seeing adoption across multiple specialties. We're seeing, behavioral health, case management, pharmacists want this, nurses love it.
Surgery? Surgical?
Surgeons are liking it as well. When you look at our data, I'd have to look at whether or not we had enough users. With the surgical specialties, they weren't saving as much time, but they were using it.
Yeah, I have a quick question. Great conversation here. Regarding Ambient and the implementation, from a provider perspective, when I've done this in the past, some of our providers have complained about the translation from the patient notes going into the record. That sounds off. Now, in your case, you're a clinician, so it wouldn't matter. I'm pretty sure you sound very astute, but some other patients, right, that may not sound as, all of these things, accents gets ingested into the record. The clinicians, my clinicians at that point were saying that they didn't want to use it because it was reflective of their input into the medical record, and they had to go in and make those changes. So how do you see getting around those kind of nuances, no pun, into the record itself coming from the Ambient solution?
Meaning the Ambient solution was inaccurate?
No, it's not inaccurate, but it was actually ingesting too much words from the patient's perspective that wasn't necessarily. I heard a doctor said to me, it makes it look like the doctor is inputting inappropriate wording that the patient is actually saying.
Got it.
Make the record doesn't look legitimate.
Right. And so that's where the flexibility comes into place. So you can adjust the type of input that you put into it. So for instance, as a PCP, I like bullet points, and that works great for me. As a psychiatrist, they want quotes. They want the actual patient words in the visit, and you can adjust that up and down. And so again, it's based on your specialty, the visit type and your style. And that's where I think, again, we have to think about ambient technology in such a way that it needs to be that amount of flexibility in order to increase adoption.
Great. All right, Kamal, you can
Yeah,
input.
I a few comments on that. So first, I have sat on the technology governance of a large health system for several years, and so I'm going to tie it back to Cletus's point in a second. So going into thinking about ambient scribe usage, the first thing I want to highlight is that when I called to make an appointment, this is an appointment we had to call. I actually asked, do the providers use this technology? And the clerk was like, no one's ever asked me that. Which I thought was really, sort of interesting, right? And so in going in for the visit, there still is, I would love to see a time where it's just part of the fabric. There still is some stumbling that's required to sort of, turn it on and all this stuff. And I remember I had this moment to be like, wow, I'm on now, right? In a slightly different way. And I think, as people get more in tune to that, it is currently a barrier to adoption, I think, in some ways, but certainly shouldn't be one longitudinally, right, as people get more accustomed to this. I think one of the things that I noticed is that, you have to verbalize more, right? Both patients, but also providers, right? And I was I don't know if Kathleen is here. There she is. I want to tap you a little bit to talk about what we were talking about yesterday in a second, but I'll just tee it up. We were talking about kind of obviously the documentation, the time saved. There's a little bit more data on that, but how does ambient technology impact the patient experience? We don't have peer-reviewed publications yet that show, by implementing this technology, you have improved survey scores, right? There's anecdotal evidence, there's small evidence, but remember, these care experience scores have tons of implications, right? On the ambulatory side and certainly on the inpatient side. CMS star ratings, 33% of those is related to care experience scores. So this is a really interesting strategy that I don't think people have unlocked in that same way. But Kathleen and I were talking yesterday. Do you want to talk about sort of at least from the nursing perspective, what's come up?
So in the interest of full disclosure, this is Heidi's up there. I am with Microsoft, so different solution. So the nurses that we have that are utilizing the solution, it's pretty interesting hearing their experiences. So they are active in med surge. They record everything the patient says, everything the nurse says. And essentially the nurse does their assessment. And there's this whole process in Microsoft world, we call it care out loud, where the nurse actually has to verbalize their assessment, which as a new nurse, I was trained to verbalize my assessment, not necessarily the nurses that are most recently leaving nursing school. So what we found is that the nurses with more experience actually are much more comfortable talking to their patients and their patients talk to them, whereas the nurses maybe with lesser experience don't quite have that comfort level. So there's a lot of practice it entails for them because you're going in and you're saying, hi, Mr. Smith, I'm here to do your assessment today. I'm going to record it, or they already know they're being recorded because it's part of their admission process. And they walk through their assessment and they said, oh, tell me who the president is, what day of the week it is. They do their whole neuro assessment, et cetera. Your lungs sound, you may have some rales in your right lower lobe. Oh, what does rales mean? It means you might be a little wet, or, you're here for pneumonia. So there's a lot more interaction with the patient because you have verbalizing your assessment to them. And the patients feel that they're more included in their care. The patients feel like we have actually seen proven improved patient HCAHPS scores because they feel like they're being communicated more and they have a better experience. The nurses feel like they get their documentation done in a more timely manner. They don't have the overtime. We don't have pajama time as nurses, but we do have what's called incidental overtime where you have to stay to get your documentation. And the other thing is that think about the care coordination aspect of this. If I do an assessment at 8 a.m. when I come on shift as a nurse and it gets ambiently recorded and then I go about and take care of all my other patients, I'm not waiting till 10:30 or 12 noon to input my assessment into the electronic health record. So there's not as the potential delay of care. The other providers, PT, OT, speech, they're all going to see my assessment right when it's done versus many hours later. So hopefully that helps.
Yeah, I love that. And I think that, upskilling people to talk sort of more, I think is an interesting, phenomenon, right? Especially as you're saying, there's, sort of when you trained gap. And it sort of, as a quality and safety leader, I think about, wow, like how could that impact readmissions and things of that nature? So one other point that I want to mention, Shahad, before I'll turn it back to you is in in my sort of experience as a clinician being cared for was I really thought a lot about the physical space and how, as you sort of have to, as you're able to move away from that desk, right, or that sort of cart, right, how can you think about the physical spaces and promote better sort of healing, better interaction that way? And I think, obviously no one's going to sort of renovate their spaces unless they have to, right? But as we think about this, I really think there's a really interesting opportunity. I reflect as an OBGYN provider. Oftentimes, you've got the big desk with the computer, you've got a cart. If you need to wheel an ultrasound in to see, you're like sort of jamming it in between two things. How can liberating yourself, right, from some of that help with ergonomics and spaces, I think is really interesting.
So one thing and I'll bring you in just a second. So one thing to answer Cletus's question, which is it's an ideal question for you as a quality person, because if it turns out that the AI is not smart enough to properly weed out what the patient said versus what the doctor said in reactions, that becomes a potential legal liability in certain circumstances. Have you seen that discussion come up in your governance meetings?
It's interesting. It hasn't come up in detail, but I think it's also because, Cletus, I'm not certain that I'm not certain that we've really looked I think that what the patient is saying is true gold, right? There are signals in there that are really telling as to how systems and structures need to change. And if I may, I was going to talk about this a little bit later, but if we think about quality and safety reporting, right? The Joint Commission, wow, I'm going like all out today. STAR, Joint Commission, all the favorites, right? Joint Commission, Joint Commission and National Quality Forum just released a new serious reportable events list. Okay, the most unsexiest thing ever, right? But it's really important. First of all, this new list, which I happen to be part of the technical advisory for, before everything was inpatient and now it's all care settings, right? So that really matters for what we're talking about. The second really big shift was it moves from never events only, things like fire in the OR, things like taking off the wrong body part, right? To more sort of common things. Undiagnosed deterioration, right? Delay in diagnosis, failure to act on tests, right? All of a sudden now, right? It's not just when harm has occurred, but the potential of harm, right? And so the signals, the what the patient said, what the doctor said, right? Putting that in a note, I think, can be worked on. Like, that's not that hard. But what I think is that there's the harms that happen that we know about, but we know that for every harm that happens, there are hundreds, right, in the inpatient and outpatient setting of sort of near events, right? So what if a patient came in and said, you know what, I just got discharged for heart failure. I'm calling, I need to be seen because the medication that was prescribed to me was the wrong dose. Happens. Right, it happens. So in that moment, right, that patient's problem will be fixed. But what if 500 patients over the course of the year said that, right? All of a sudden, it's not a one-off, and it's something that structurally can be adjusted for and fixed. And so I think that, one of the really most amazing promises of ambient technology, inpatient, outpatient, all settings, are exactly that, right? I don't understand this is why I'm a certain way, right? Those are the things that we as sort of improvers of care can really work on.
No, it's a great example. I know you wanted to jump in on the last comments, maybe by Kathleen and by Komal, but if you can add on this idea that as a PCP, obviously you spend a lot of time with patients in the office, but a lot of time you also are on the phone with them post-visit, pre-visit. Does any of that get captured in your experience so far?
So you can use the ambient for any kind of documentation. You can, at least with the tool that we have, we can write letters, we can do prior approvals. We've seen some of our docs who are part of utilization review summarize information to bring back to the insurance companies. I think, there's lots of uses. I did want to actually go back to the idea of the patient experience, because I do think that this is an area that we really haven't looked at. And you and I were having a conversation yesterday, like, when would you not use an Ambient? So, you get permission from the patient. And there are times.
Somebody said no to you?
So less over time. So I would say in the last 6 months, nobody has said no.
Okay.
But when I first started this over a year ago, sure, people were like, what is this? Why do you have to do it? But in the course of a visit, if a patient is having an emotional moment, I will reach over, say, let's take a pause, shut off the Ambient, let's take a breath. And what that makes me think about is that, and I don't do that because I think the Ambient technology is going to misinterpret the emotions. I do that because I worry that the Ambient technology is going to prevent the patient from fully expressing their emotions. And they're not going to tell me that. So I think we need to do a little more research into, okay, what are patients not telling us because the Ambient is there?
I really appreciate that, Nancy. I think it's a really great point. Things that have also been rattling around in my brain on that same topic is the sort of virtual versus in person, and are there differences in what people aren't willing to share? You're in the comfort of your home and you're being sort of listened to, right? Does that change at all? I think we're just scratching the surface.
Yeah. Quick market research again. Who has gone through an Ambient patient as a patient with your doc?
Ooh.
Nice. So yeah. And by the way, if you have any experiences there, this is the place to do it. So anybody want to share good, bad, the ugly, whatever it is, just tell us. Maybe we'll go Becky first, and then I saw some Heather names hands back there, but whoever's got the mic can grab it. So anybody who's been a patient in that experience, let us know.
My experience was in taking my younger son, so it was a pediatrician. They did a great job of explaining, hey, we're gonna just record. They didn't know that my role had been working in technology to, facilitate adoption. So it was great to really kind of truly be there as a patient and a family. And I was impressed with the quality of the note. That it just really captured everything a little bit more, it had a more warm tone to it, in the 8 minutes that we got with the pediatrician. The thing, I just wanted to kind of circle back around on, the concern about the quality of the note or the accuracy of the note. Has anyone in here ever seen someone use a template and get things wrong?
Great point.
And I know the point was made even yesterday, like if we find mistakes in trying to go back and correct, anyone have that experience of trying to go back? Fun, right? It's so incredibly painful, I think, to try to get a note corrected where multiple phone calls back to the health system when you know how the health systems work, which I think is really frustrating. So I do think, while there is this, to me, it feels like an imaginary fear of, oh, what if we get the note wrong? I'm like, there's mistakes that happen all day long in the world of healthcare. The templates aren't any better, and we need to make sure that patients do have an interactive way and an easier way to get those things corrected. There are some patient portals out there that if I don't review the note that the doctor wrote within a certain time frame, and if I don't respond back to that doctor within a certain time frame, I can't message that provider who might be my primary care provider.
Yeah.
Like, we are making barriers. It should be, if I have a problem with my Amazon shipment, I can chat with someone very quickly. So we've got to get over this fear of like, what if we get it wrong? You're right. You might get it wrong. So let's make it easier to get it right.
And it's not even like an A grade, right? You're talking about the PASS system and small sort of reviews where patients have gone in and looked at their notes. It's something like 10% have errors. Like, that's not minor, right? Certainly the technology is doing better than that.
But I don't have a sick pediatric patient. We're not going underneath a chronic illness. I have healthcare. I have access to things. And if it's hard for me, I know I'm not the brightest light on the island. So, but if it's hard for me, then imagine what is happening to all these. So I really think that we need to jump into these things, figure out how, like, are we 80% accurate? Okay, great. 80% is better than what we were before, and keep moving.
I think I love that. And I think just the comment in the prior panel about, education and upskilling that both Brandon and Paul made about, what is possible, how does this work, capacity. I want, the patient facing component of that too, I think is really interesting. Like what to expect, what it is and it isn't, I think is an interesting conversation that I imagine. I will say my provider didn't say a single word to me about I'm turning this on now. This is what it is. You know what I mean? And maybe there was an assumption because I'm a provider, but I think there is some level of equipping people there.
Great. And you feel free to comment. And then if somebody else wants to comment, we'll get the mic over to you. Go ahead.
Yeah. So just in that experience, pre-using this technology, I'm a primary care doctor. I talk to you about everything and anything. There may be 10 things we discussed. I documented 9. What happens is 2 weeks later, Mrs. Jones is calling about her toe pain. There's no toe pain in the visit because I forgot to document it. So I think, again, the comprehensiveness of the note is really important. But as you point out, the patient voice, I mean, we have gotten so used to templates, smart phrases, dot phrases. Our notes are huge, but somehow the patient story is lost. There is no patient voice in that note. You can't tell what exactly they were worried about. And that's where this technology can bring that back.
Anybody with a worse experience or other comments? I would love to hear anything that, because we're doing live market research here.
Yeah, I'll just talk about the recent exposure to, I think it was Sharp Healthcare and Abridge and the issue they had there with the consents, right? So I think everybody's aware of what's happening there.
No, give some background. Go ahead.
So I think there was a patient at Sharp Healthcare that did not consent or thought they did not consent to being recorded by the ambient listening. And so I think they're suing somewhere in there. I don't know too many details, but essentially, the patient felt like they didn't have the opportunity to consent. So they're holding both firms liable, whatever it might be. So my question around this is, where do you see us at 5 years from now? Because I think today, everyone probably has an Alexa in their house somewhere and it's listening, right? We will be used to this 5 years from now or 10 years from now that you go to a doctor's visit and the assumption is being made. This is just how the visit's going to go. And we're not at that point yet today. So consent is something that has to be really baked into the process. But in 5 years from now, 10 years, when do you think that might change? Because it's a process step more than technology.
It is. So we went through this, do we do verbal consent? Do we do written consent? If we do written consent, do we do it every time? Do we do it? So we went through this. And I think, again, we're learning. We decided as a system to make it a verbal consent with each visit because it gives the opportunity for the patient to say yes, no at each visit, or like, I'll do it for this visit for my annual, but I won't do it for my behavioral health consent. I do believe we're going to get to the point where this is just going to be part of what we do because it is a better experience for both the patients and the clinicians. And it will probably be part of the general consent of any health systems. I don't think we're there yet. I think we're probably, I don't know, a year or 2 or more.
I agree with you. And I think each health delivery organization is grappling in different ways. Some of the things I've been heartened by seeing is, just as again, thinking about those most apex events, right? That made national news. People are talking about it, but there's so many other things that happen, right? What I've been heartened to see kind of and speaking with other leaders is at the very most, when you start adding conversations into root cause analyses, which are, sort of analyses of the most serious events, that then trickles down into other things, right? And so over the last 5 years, there's been a lot more conversation about structural barriers and inequities and how they might have contributed to whatever outcome we're seeing. I'm also now starting to see a lot more of people talking about the technologies that were utilized and how they helped or didn't help or may have contributed to whatever outcome. So I certainly agree with Nancy, like we are not there. But the fact is as we start to bake this into those conversations, we're talking about risk profiles, we're talking about including it into the analysis of the day-to-day things that people are seeing in healthcare.
My feeling is that, and I'll get to your question in just a second. My feeling is that I've been talking to senior executives at hospitals, reminding them that there are now, in general, practically speaking, free video zones where once you walk into that zone, you get a sign and you're told, hey, you're under surveillance. If you don't like it, walk away. Right? That's in general. So now, the hospital execs that I've talked to think that I'm crazy when I say this, but I'm saying just start putting up these signs. If you're serious about ambient, it's got to be ambient everywhere, which is why I brought up the phone call. Because if you got everything right during the visit, but then you didn't track what happened to the phone call an hour later, where there's a lot of interesting questions that are being asked, somebody forgets something, family wants to call. So if you're truly serious about ambient, just assume it's ambient everywhere. Like you don't put cameras in certain places but not others. You just say you're under surveillance for security purposes, et cetera. And I'd love to get your opinions there and from the audience.
Sounds a bit harsh.
It does, definitely. That's why they think I'm crazy, right?
So I think it is interesting. There is a little bit of cognitive dissonance, right? Like any meeting that I have attended now has a note taker, right? Like serious meetings about serious privileged things, right? I mean, like, did a meeting occur if there wasn't a note taker there, right? Like, and so I think you're right, but there is
The
this
AI note taker.
yeah, exactly. And so there is this interesting dissonance, like that's different,
Yeah.
right? And it's not really.
It's not. No, there's no difference. Yeah, absolutely. Yeah, we'll take your question and then over there.
On. I want to go back to something that Nancy said. It just made me think. So the toe pain example. So, I work former ER doc. I work in urgent care, and patients will come with certain complaints, and we all know about heuristics that providers will use, and there's a number of things, right? Because the brain tries to make things simple, and that toe pain could be a lot of dangerous things, right? That could be vascular insufficiency that turns into a dead foot or dead leg. That could be, a diabetic toe infection that turns into osteomyelitis or anything. So I guess my point is, we like to try to simplify things, especially when we're busy. So something like that, where you're getting the full story and it puts it there, as you said, Nancy, you forgot the 10th out of those 10 things. I think there's an opportunity here for us to see both gaps in care potentially being closed because, okay, it caught that thing that I know I need to refer them to a podiatrist to, and or decrease in patient harm because the transcript caught it where it went in one ear and out the other because we're humans. And I doubt anyone's gone there yet, but I think that's a potential good opportunity for this to when you capture the whole thing and then look at it later.
So there was, an interesting conversation yesterday about, deploying AI leading to harm and potential death or, bad outcomes.
Yeah, I said we're going to kill somebody.
Yeah. I wasn't going to say that, but I think, and this was a question that was posed to one of the AI researchers at BIDMC what do you expect to see in malpractice, regarding AI in 2026? And the answer was, I expect to see a malpractice suit because AI wasn't used. It wasn't that because it was, is it because it wasn't used? And I do think that is probably where we're going to go because, again, this is something that provides better care. And we're, whether we're talking about ambient or the other technologies, that's where I think, we are headed.
Yeah. What's funny is, and so we'll take your question next, but while you get the mic, what's funny is that the ambient part of this is the data entry part. Instead of the keyboard, you're using ambient. The rest of the stuff is what we're supposed to be doing anyway, right? And that's a fantastic point is if you're just talking about ambient as the tech, that's not the tech, that's the input. The tech is that the discovery occurred and the note got taken and then the next step and the care gap, et cetera. And so your point is so astute is that like, we shouldn't be talking about like we have cool keyboards. That's what the ambient part is, cool keyboards. But let's start talking about once you got the data in, what do you do with it?
I'm going back to what Mike was talking about earlier about AI capturing utterances and your mention of translation. So when we're so dependent on AI now to do things like translation, how do we know it's correct? How do you know it's correct?
Yeah, that's a great question. So we don't use it as an interpretation service. what we do use is that if we have a bilingual conversation, if a clinician is bilingual, having a conversation in Spanish and then the output is in English, they can create a patient explainer to give to the patient in their native language. So we're not quite at the point, and I only can speak for Massachusetts, but interpretation services require a certified interpreter to intervene. So we're not there yet. Is that around what your question is?
Yes, and
Yeah.
I was just, the necessity of human in the loop
Yes.
for that. Okay.
Yeah. And I think in general, I'm very much clinician in the loop. We can talk about where we can go with this. But I firmly believe, and Heidi firmly believes, that the clinician needs to stay in the loop.
Yeah, in fact, that was the question coming up. Is there anybody else that had anything to add? Yeah, Mohan, go ahead.
Yeah. No, it's on. I have been involved with Ambient and other like technologies in the physician's room. So I enjoy it. I think it has value. I think that it's incredibly interpretive and it's powerful for removing the problem of the lack of eye contact between.
I hear a Mohan butt coming.
No. There's
Good.
nothing wrong with my butt. But it's a matter of judgment. I do think that my research is showing that there are variations in license agreements between these necessary technologies in the form of whether they can use whatever recordings as training data.
Yeah.
And how does a patient even know to ask that question? Because you can say I consent, I don't consent, but I seldom want to consent for training data personally. You can get trained on something else, not my situation, because I'm selfish about it. It's my data. So how does one discern that in the practice?
That's a good question.
Yeah, it's a great question. There was a Wall Street Journal article not that long ago that your physician's using AI. What 5 questions should you ask? So when BILH went through the process of looking at various solutions out there, we were very clear. We did not want the data to be de-identified and to train their model. That was a non-starter for us. We also were very clear that data is, going to be deleted. So, you have the transcription, you create your note, and then that information is deleted. So it doesn't go anywhere. And we've put parameters around it. If the clinician forgets to delete it, then we will automatically do that. But yes.
I think that's an interesting point. I also think this topic of when do you delete, and like you said, license agreements vary by institution. But as we think more longitudinally, the comment about, well, the toe pain could have been the most relevant thing that we need. And so I think we're only beginning to scratch the surface to really think about how do these raw sort of transcripts help harm us in our ability to deliver care, and also the risk that's associated with it.
Yeah, practically speaking, I think we're not going to have a choice. We're going to end up, regardless of what the license agreements are today, long-term, the trajectory is everything is going to be used for training data. Done, right? And once that's the case, the question is it de-identified well enough? Just from a purely mathematical perspective, there is no such thing as de-identification. Right? So just everything is re-identifiable. And that was before AI, right? Just traditional, without LLMs, traditional ML, you could re-identify fairly easily. But, as a vendor who has long-term collected data for a long time, we always tell our customers, of course it's de-identified. We forget to add on, but it can be re-identified, right? Nobody tells you that. So just ask about that question. Now, that having been said, I think for sure we're all, in the end, going to consent just automatically, because just walking into certain facilities will just mean you're going to be recorded, you're going to be attached to some record, if nothing else, just for security, right? You walk around in any city, you're being recorded, all kinds of stuff is being recorded about you. So it's just some things that we're going to, as older people, have to get over, because the younger folks have already moved on as well. Oh, there's a question here, please.
Yes. So I have, I wanted to hear your input in when do you see this will be part of like the clinical educational academy? For instance, residency training, even medical school. As a foreign medical graduate, we have to go to this, one of the boards that we have to pass is like going to that simulation where you have to assess the patient and so on. Where one of those patients now will be, not now, but in the near future, will be one using Ambient AI and see how you as a resident, potential residents will be using. And to the in mind, residents that are working today in healthcare facilities were using Ambient AI, and then now they graduate. Are they going to have an advantage in deal like a really good contract in hospitals where they want to hire these residents because they're already familiar with Ambient compared to other ones that didn't?
Yeah, that is a great question. So I mentioned, 13 hospitals, 3 academic medical centers. The question came up, should we let our medical students and residents use, ambient technology? And of course, you got 3 different opinions. One said, go for it. The other said, no way. And the other one was like, yeah, maybe. But it begs the question of, this is a technology that is going to be part of every new physician, clinician's life. Is it better to teach them how to use it appropriately and properly versus versus giving them time to develop the skill set of note taking? So I'm not an expert on graduate medical education. I think it's tough. I don't know necessarily that they will have an advantage as they go on to whatever their next institution is, but I do think we as educators need to figure out what does that look like.
It strikes me as that is like, there's some universities that penalize students for writing papers with AI. I mean, what kind of idiot? A university would say we should not prepare our students to use AI in the proper way, right? I mean,
yeah, no, universities are lying to their students. And if you're being lied to by your university, go to another university. If you're not being taught how to use Ambient AI, go to another university.
Yeah, I think the topic of simulation for graduate medical education training, it's ubiquitous, right? The ACGME requirements, they include some aspect that can be met by simulation. Certainly in nursing, there's amazing recognition of the importance of simulation in training. And I think your point is well taken. How deliberately the EHR, ambient technology, other sort of technologies that are utilized in the clinical environment are incorporated into those modalities really depends. And what I've seen really in multiple settings is how close those structures sit to the governance around some of those things. And so do the people who are the educators, quote unquote, the leaders of education, how their ability to sort of navigate getting those technologies into the center. So some don't and some do, and it really depends on that sort of relationship. But I think to your point, there's no reason it shouldn't, and in fact, it must if we're going to move forward, right?
And we are out of time, so we just give a big round of applause to our panelists. But we're going into a break, which means feel free to come up, ask some questions, and they'll stay here for hours and answer them. Please come.